today through another interesting topic, ADPKD and its complications. Again, thank you, our conveners, Dr. Vijay Kher and Dr. P Varma, for giving us this opportunity. And with this, I hand over the session to them. Thank you so much.
Puneet, it's a pleasure to be again today in the master. A very common that is auto policy and its we had a very senior nephrologist, a very learned nephrologist, who is heading the Department of Nephrology at Army Hospital, to please conduct the case for us. And he is the examiner for today. Dr. Ravi Prakash, student, he is going through the case, and none other than Professor Dinesh Khullar, who is a leading nephrologist and a doyen in the field, learned nephrologist, respected by all. And he is the expert today. So he will be giving us nonsense about ADPK, what is new and what we all need to know more practically. And we have got expert who is another doyen in the field of nephrology, Professor Amit Gupta, ex-professor of SGPGI, and presently at ApolloMedics at Lucknow. I think before we proceed further, I'll request Professor Vijay Kher. And those of you, I think, who are joining now, just I must remind you, when I was appearing in DM exam almost 33 years back, and that is the time Professor Kher was my examiner, and he examined me on the ADPKD case. So that becomes very dear to me, Professor Kher, sir.
Thank you, General Verma. And I think although we have progressed both in understanding as well as management of patients of autosomal dominant polycystic kidney disease, and in the days when General Verma was a student and was appearing in the exam, we didn't have any such therapies as such. But there is still a lot of unmet needs in autosomal polycystic kidney disease, and I think still some challenges. The treatment has side effects. Obviously, there are adverse effects. The optimal dosages which are being used in the trials, and many of the Indian patients were not able to achieve those kind of dosages. And still, I'm not so sure how many people are using or giving the usefulness of this drug. The impact of the drug also in the trials is not something very massive. Yes, there is an improvement in the slowing down of deterioration of kidney function over a few years, but there is still an unmet need that we must have maybe more prognostic as well as diagnostic markers, biomarkers. Genetics is available, but is not being utilized, at least clinically. And therefore, that may be another unmet need, the utilization and frequency with which one needs to do it. But there are challenges there as well. And of course, there is a need for increased number of other drugs. There are some newer drugs which are being developed, but at the moment we don't have data on any of those as yet. But we do hope that the future is going to be better with this. But there are no doubt, and I think patient-related outcomes in the real-world data, at least from India, that's not there. And I think we probably need to look at those avenues as well as we progress in better understanding of autosomal polycystic kidney disease. And that's the reason why this topic is here. I'm sure you're going to be better off after the today's 1.5 hour of discussion, both clinical as well as I'm sure Dr. Khullar is going to give you some inputs into not only what is currently being done, but also into some of the future things as well. With this, I think I will request Dr. Manu Dogra and Dr. Ravi Prakash to go ahead with the case. Dr. Ravi Prakash, you can start, and then Dr. Manu, you can take over.
Sir.
Dr. Ravi, please start.
Yes. Good evening, sir. Sir, today I am going to present the case of ADPKD along with its complications. So, my patient is 35-year-old male, serving soldier by occupation and study till graduation. Reliability is good. And he is a known case of ADPKD, PKD1 truncating mutation. Admitted with fever, hematuria, and left flank pain of 10 days duration. The onset is in 2018. And so we will discuss the presentation in the chronological format to understand the initial presentation and then all the complication he had gone through. So initial presentation was in 15 September 2018 when he presented with recurrent episode of hematuria for 2 months, right flank pain of 6-day duration and high grade fever with chills for 3 days. So at initial presentation there was recurrent episode of red color urine. There were total of 4 episodes. All were following exertion after running, lifting heavy weights and happened over a they were vomiting each 2 days, no urine output, of fleshy material, and right flank pain was 6 days, radiating to the right lower back, constant and debilitating. Patient became bed-bound. There was no history of radiation to groin, no passage of stone or strangury, and partial relief to NSAIDs and heart fermentation. There was associated fever for 3 days, moderate to high grade, intermittent with chills but no rigors, and relieved with antipyretics. He had a similar episode of hematuria following exertion for a decade back, and 3 such episodes, all were self-limited in a day. There was no any preceding URI.
Ravi, you have shifted one slide. Please go back.
Yes. So other history, there was for negative history, heaviness of.
Sorry for interruption. You said there was a similar episode 10 years back.
Yes, sir.
This episode was in 2018. So in 2008 also he had hematuria.
Yes, sir.
Okay.
So, and there was also associated nausea and intermittent vomiting, and there was loss of appetite. There was no any history of heaviness of abdomen or abdominal distension, cramping in the abdomen, diarrhea or constipation, seizures, headache or focal neurological deficit, palpitations or breathlessness, joint pain or skin rash, abdominal, right, dysuria or lithuria.
Ravi, no history of ADPKD. Patient presents with hematuria, has a flank pain, and
yes, sir.
Okay. So, of this negative history.
Sir, in that negative history, we to rule out the causes of painful hematuria with fever. So, and also we are trying to of ADPKD since.
Just don't think that the patient has got 18. Nobody knew that he's got ADPKD. That was the first presentation.
Sir.
So, what are you implying at by this negative history?
Sir, in this negative history, I am trying to rule out any renal calculi disease, sir. First, that is the most common presentation of fever with hematuria, and any glomerular causes of hematuria, sir, by taking the history of preceding URI, dysuria or lithuria. Then any trauma that can lead to painful hematuria, sir.
But he had painless hematuria or painful. You said he had a painless hematuria.
Painless, sir.
Yeah.
So how do you divide hematuria?
Sir, hematuria.
Causes of hematuria.
Sir, causes of hematuria broadly can be classified based glomerular hematuria, sir, and non-glomerular causes of hematuria. Sir, glomerular hematuria, the most common causes are IgA nephropathy, sir, and then thin basement membrane disease. that generally present with frank hematuria. Other causes less likely FSGS or LPOTS can present with hematuria, sir. And then there comes the non-glomerular causes. In their first is infection, acute pyelonephritis, renal papillary necrosis can present as hematuria, sir. Then tumors or malignancy, renal cell carcinomas present as hematuria. Then renal stone disease, sir, or can present as hematuria. So other urological or obstructive cause can present as hematuria. So these
Cancers, RCC.
broadly non-glomerular.
Okay.
Okay.
Now,
Yes, sir.
what is the diagnostic criteria for glomerular hematuria?
Sir,
Diagnostic criteria.
Sir, for glomerular hematuria, there should be at least 5 acanthocyte or 1 RBC cast in per 50 high power field, sir.
And
And
what is
there
the
should be,
45 and 1 rule?
sir, 45 is 40% of the dysmorphic RBC, 5 acanthocyte and 1 RBC cast, sir, for diagnosis of glomerular hematuria.
Okay. What is the role of urinary albumin to protein ratio in glomerular hematuria?
Urine protein ratio generally falsely came high in generally there is proteinuria also falsely high in cases of hematuria. A rise in if there is significant rise in urinary albumin creatinine ratio, then it might suggest that there is more goes in favor of glomerular cause for hematuria.
Okay, but the contrary is true. If the albumin to protein ratio is less, the chances, the probabilities of tubular is more as compared to glomerular. That's what the studies have shown.
Yes.
Please proceed.
So, a past history, he had similar episode of hematuria following exhaustion a decade back. 3 such episodes, all were self-limited in a day. No preceding URI, dysuria or lithuria, no associated fever. Never evaluated further as he never reported. No heaviness of abdomen or abdominal distension. No seizures, headache or focal neurological deficit. No chest pain, palpitation or dyspnea on exhaustion. No flank pain or passage of fleshy material in urine. No intake of NSAIDs or CAM.
Okay, now stop here. You go back to the previous slide.
Sir.
Now you have a history that suppose you knew that this is a patient of ADPKD.
Yes, sir.
Okay, so why are you asking all these questions? Can you deliberate on that?
Yes, sir. So initially, we are asking for any heaviness of abdomen or abdominal distension to rule out any colonic diverticuli. That can be one complication.
No. It is the size of the kidneys.
Sir.
Heaviness as well as abdominal distension determines the size of the kidneys.
Sir.
The bigger the kidney, the more the abdominal distension as well as heaviness of abdomen.
Sir.
Next.
Sir, there is no seizures, headache or focal neurological deficit. So in the patient with ADPKD with intracranial aneurysm can present with these manifestations. Then we are asking cardiovascular system history of chest pain, palpitation and dyspnea on exhaustion to rule out any valvular diseases, and no flank pain or passage of fleshy material in urine. We are asking for any renal papillary necrosis, sir.
Proceed. Yes.
Then in the family history, as we can see in the pedigree, there is no any skipping of generation. The grandmother died at the age of 69 years, and paternal uncle died at the age of 70 years. However, the cause of death is not known, and he had 68-year-old, and he's a known case of kidney disease. However, the exact nature of disease is not known, but on history taking, patient said that he had some cystic lesion on ultrasound imaging. So there is no any history of hypertension, diabetic and renal calculi disease, no history of stroke or seizure.
So all the generations are involved.
Yes, sir.
In this.
Yes, sir.
So what it could be?
Sir, is the all the
dominant?
Sir, it's a more likely a autosomal dominant disease, sir. If it would have been X-linked dominant, then the From mother, the disease should have been passed on to the daughters also, but there has not been any such case.
What all autosomal dominant renal diseases do you know of?
Sir, autosomal dominant disease could be autosomal dominant polycystic kidney disease, sir, and autosomal dominant tubulointerstitial ADTKD kidney disease. Then, sir, von Hippel-Lindau syndrome, tuberous sclerosis, sir, and thin basement membrane disease. These are the, sir.
So, how do you differentiate between ADTKD and ADPKD?
Sir, in ADPKD, generally the cyst, the kidney size is bigger. There is early presentation and a rapid progression to end-stage renal disease. And in autosomal dominant tubulointerstitial kidney disease, generally the kidney size is mildly increased or within normal range only, sir. And there are associated features of hyperuricemia and.
Okay.
Sir.
Please proceed.
Sir. In personal history, he consumes mixed diet, married for 6 years with one child aged 4 years and has no addictions. So, summary, so a 35-year-old serving soldier having history of exertion-related recurrent hematuria for 10 years has now been presented with repeated 4 such episodes of painless frank hematuria following exertion over past 2 months with episode being associated with right flank pain of short duration and high grade intermittent fever for 3 days without any significant systemic involvement, and he also has a strong family history of kidney disease.
Dr. Ravi, you said that we were talking about hematuria and
Yes,
and then a degree of proteinuria. Would hematuria by itself produce, say, a large amount of proteinuria, say 3 grams of proteinuria or so, or would you think that when you have 3 grams of proteinuria, you will have to look at something else?
Sir, a hematuria can lead to, sir, some amount of proteinuria, sir, but at the value of 3 gram of proteinuria, we also need to look for some other causes, sir, in patient.
So you will look at glomerular causes. So
Yes, sir,
hematuria
glomerular.
by itself, say
Yes.
an extra renal hematuria, strong, you have a frank hematuria. So this degree of proteinuria will not be there.
Yes, sir.
Okay. Yeah, that's important. That when you have large amount of proteinuria, because many people feel that you may have small degrees of albuminuria, proteinuria when you have hematuria by itself, overt hematuria. But nephrotic range proteinuria always reflects a glomerular onset of hematuria.
Yes.
Just one, I wanted for my own information. You gave stress on following exertion. Repeatedly, you gave a stress that you develop hematuria following exertion. Is it exertion related always in ADPKD? Or it can develop otherwise also?
Sir, in
Because
ADPKD,
exertion related hematuria can occur in the normal kidney also.
yes, sir.
If you have got normal person, healthy person, like athletes and all,
Yes,
if
sir.
you are exerting or going for a run, a significant number of people will develop hematuria.
Yes.
Like something like we did a study of 500 patients. It is published also. And for army soldiers only, in your institution, I had done that. So we had taken 500 people in the morning BPT. So they ran for 5 kilometers and came back. 15% of them, 14 point some percent, develop hematuria, and some of them macroscopic hematuria. So exertion will cause hematuria. But is it required always for ADPKD?
No, sir, the dehydration episodes, sir, generally that precipitates an episodes of cyst hemorrhage, but otherwise also a ADPKD patient can present with hematuria, sir, without any exertion also.
It will be generally a painless or painful hematuria.
Sir, it can be painless and painful also, sir. Generally, painful hematuria is seen in because of because it's most commonly involved with an episode of nephrolithiasis. That is the
Okay. And why this hematuria occurs?
sir. This hematuria, sir, generally due to any intracystic hemorrhage that lead to coming out of blood in the urine.
Okay. Okay. And you said fever also.
Yes, sir.
You mentioned there is a history of fever. What is that pointing to?
Yes. Sir, there was also a fever, sir. So fever with hematuria in ADPKD can be present in cyst hemorrhage also, and also there could be any underlying infection that can lead to fever in patients of ADPKD, sir.
But Dr. Ravi, in case there is a cyst hemorrhage,
Yes, sir.
it usually, until it's infected, it does not cause moderate to high grade fever. It will just cause a low grade fever and pain, nothing
Yes.
else. But in case this is high grade intermittent fever, that too for 3 days, so you
Yes.
have to think about an infective cause.
Yes.
Okay. Can I ask a question, Professor Kher, if you permit
Yeah,
me?
yeah, yeah. Please, please.
No,
You are free to do whatever you want.
3 grams of proteinuria, is that usual in a patient? Like I thought Dr. Prakash mentioned that 3 grams of proteinuria, if you have large amounts of proteinuria, you think of a glomerular disease. So would that be associated with a patient with autosomal dominant polycystic kidney disease?
No, sir. 3 gram of proteinuria in patient of ADPKD. Sir, then we should look for any other cause also, sir, in such
Is it
patients.
a glomerular disease or tubular disease?
Sir, glomerular disease, if there is a nephrotic range, proteinuria
No,
is.
no.
Asking
That
whether
is asking ADPKD
ADPKD
is
is
the glomerular disease or a tubular interstitial disease?
The tubular interstitial disease, ADPKD, sir. Polycystin gene is there in the tubular basement.
So would
Do
you
you
get
expect
large
this
amounts
much
of protein?
proteinuria? Dr. Amit has asked you that. Do you expect a 3 gram of proteinuria in ADPKD?
No, sir.
Okay, I think you can go
So
ahead.
that's a little unusual. And the other point that he made was that there's a rapid progression of the disease. Does ADPKD progress rapidly?
Sir, sir, it depends on the nature of the mutation and what.
If you compare
Um,
ADPKD progression with, say, diabetic nephropathy or diabetic kidney disease or with glomerular disease or with hypertension, where does ADPKD stand?
Sir, generally slower, sir. It take 2 to 3 decades to progress into
Slowly
CKD after
progressive disease.
initial.
That's one of the things that it's seen in patients with ADPKD. The drop in GFR is usually much slower as compared to other forms of uh, kidney diseases.
Yes, sir.
And in the first slide, you mentioned patient with truncated mutation.
Yes, sir.
In the first slide, you mentioned that. On what basis you said that? He
Sir,
had a
patient,
father who lived up to 70, grandmother 69. The other family member died at 70. On what basis you mentioned the term truncated mutation?
sir, we have done a NGS for this patient, and
That
on
is
the report
that is
of that.
investigation.
Yes, sir.
Here you are giving a history.
Sir, I have mentioned about that patient that we know that patient is of ADPKD truncating mutation, and now we are, sir, discussing the chronological order of events. So that
Anyway, when
Sir,
you are
he's a
giving in
graduate,
the
sir.
it's not the
exam,
path of history, sir.
when you are giving in the exam, don't mention right in the beginning he is a case of truncated. That is a investigation.
There, he may never not know it also. He may never know it. But since he has managed this patient and he knows about the patient, that's why he said that this is there.
Yeah, but if he mentions it in the exam, then he's had it.
Yeah, no, in the exam, he will not get this information. No? He will not have known the patient. And this information usually will not be available unless the patient tells him.
In the exam, if you mention, that means you know the diagnosis.
So therefore,
Somebody has fed you everything.
Yeah.
So don't mention these things.
Yes, sir.
Please proceed.
Go ahead.
So based on my history, sir, and not taking into account the previous history of ADPKD, the patient presented with high-grade fever, hematuria and right flank pain. So I would like to keep acute pyelonephritis as my first differential. And after taking into account the initial history of the patient that he is a known case of ADPKD, then I would also like to keep any upper acute pylon case of ADPKD infection, sir, since he had high grade fever.
Why did you bring pyelonephritis here? Why not?
Sir, having the imaging or the microbiological confirmation of the infection, sir. So that's why I am keeping.
What is the simplest way to differentiate?
So simplest way to differentiate, sir, we can have on imaging, we can look for any.
We don't have imaging facility.
Sir.
What will be the urine finding in the urine?
Sir, both, sir, there and cyst infection, sir, there will be hematuria would be more predominant also.
What about the pus cells?
Sir, pus cases.
Sir, there'll be. Keep in mind, don't confuse. Whenever there is a cyst infection, infection is in the cyst. If you are talking about pyelonephritis, there will be pyuria.
Sir.
But in cyst infection, you may not get anything.
Sir.
So don't confuse.
Sir.
He has got a fever, he has got a flank pain, he has got high-grade fever for 3 days.
Sir.
All right.
Yes,
so
sir.
you're talking about cyst, to think first of the cyst infection rather than pyelonephritis. Go ahead. Dr. Manu, please take over.
If the cyst is communicating with the your calcium system, then yes, you might get.
Yes.
Okay. Carry on. So your diagnosis is cyst infection because since we have a history of ADPKD. Okay. So it's cyst infection. So how do you now in case of ADPKD, what do you expect in clinical examination for this patient? Your expectations for clinical examination.
Sir, in clinical,
you know the diagnosis of ADPKD?
Yes, sir.
Okay. Now we are going to examine the patient.
Yes.
So
sir.
what all things are you going to look in this patient with a background history or background of ADPKD?
Yes, sir. So in the initial general physical examination, sir, we will look for any pallor or any hypertension, the raised blood pressure in patient of ADPKD. Then, sir, from head to toe examination, sir. For first, we will look at any in the fundus any evidence of hypertensive retinopathy or papilledema is there or not, sir. And since it in also there is a complication of intracerebral aneurysm, so we will look for the third nerve palsy. Generally, the third nerve is the earliest to be involved. And then, sir, coming down in the systemic examination, sir, we will look in the chest for any ejection systolic murmur for sir MR and sir and or any pansystolic, sorry, sir. Ejection systolic, pansystolic murmur of MR, mitral regurgitation, and sir. Then coming down, sir, on abdominal examination, we will look for any abdominal swelling, sir, if there is any.
You basically look for large kidneys.
Yes, sir.
Okay. Anything else?
Sir, and then we will any tenderness in the abdomen, in the lumbar region, and whether the kidneys can be palpated on by manual examination, palatability is there or not, sir.
Would you like to look whether the patient is in fluid overload or anything? Suppose his kidney disease has progressed into CKD or telltale signs of
the
CKD?
kidney disease yes, sir. Then we will also look for any pallor, and we will look for, sir, the arm thickness for any nutritional status, and sir, a chest examination for any bilateral crepitations and any pedal edema is there or not, sir.
Okay. Proceed.
So on general physical examination, height was 169 centimeter, weight was 80 kg, BMI was 20.1 kg per meter square. The patient was febrile with temperature of 100.5 degree in Fahrenheit, Pulse was 86 per minute. BP was on the higher side with 158 by 96 mm of Hg. And saturation on room air is 97%. There was no pallor, cyanosis, icterus, pedal edema, clubbing or lymphadenopathy there. No skin rash or arthritis. Lying on bed in pain and in partial left decubitus position. Because the patient was having severe right-sided tenderness. So urine so gross hematuria on naked eye examination. On systemic examination, on inspection, there was fullness in both the flanks. No peristalsis was seen. On palpation, irregular ballotable mass felt on both sides and tenderness on palpation in right flank and right side and renal angle tenderness was present. No hepatosplenomegaly on percussion, no free fluid or hepatosplenomegaly. Auscultation, no bruit or venous hum was appreciated. PR was not done. Sir, on systemic examination, bilateral air null with vesicular sound, no added sounds present. CVS on CVS examination, S1, S2 was present, normal, and there was no any adventitious sound. On CNS examination, there was no any neurological deficit. So dipstick was done, showing pH of 6, reddish urine with a specific gravity of 1.028, protein 1 plus, sugar not detected, leukocyte stage, nitrite, and blood 3 plus.
Okay. Should we be giving cognizance to this urine dipstick with the presence
Yes,
of gross hematuria?
no, sir. In presence of gross hematuria, sir, all the things can come out to be falsely positive, sir.
Okay.
Yes, sir.
So, what are the conditions where urine dipstick should never be, given cognizance to?
Sir,
One is gross hematuria.
yes, sir.
Other conditions?
Sir, dipstick can be, sir, falsely positive in other conditions also, sir.
Like?
Sir, likely in cases of, sir, after drugs also there has been, sir, phenoxypyridine and NSAIDs that seem to have false positive urine dipsticks, sir.
Okay.
And
In case
sir,
the patient has been given radio contrast agents,
yes, sir.
thereafter again there will be some sort of confounding. Okay.
Yes, sir.
And then if it's a very highly alkaline urine,
Sir,
then also the dipstick can be falsely positive.
yes, sir.
Please proceed.
So 35-year-old
So anything in addition you have got in this patient in this after the clinical examination?
sir, no, after clinical examination also, sir, I would like to keep the same DDs. And since now on examination there is a ballotable enlarged palpable kidney, so I would like to keep an autosomal, my provisional diagnosis as a polycystic kidney disease with likely cyst infection or acute pyelonephritis as my first differential.
Yeah, please proceed.
So initial examinations done on September 2018 shows there was a leukocytosis of T with TLC count of 25,100 with predominant polymorphs. There was azotemia with 1 of 40 and creatinine of 2.8. However, we don't know the baseline creatinine, but since he is a serving soldier and undergoes an so we are considering the baseline creatinine to be normal only. So, and there was a rise procal with of 16, of 50 to 100, albumin 1 plus, just showing E. coli, sensitive flocks and gentamicin. Abdomen, right kidney of 13.5 centimeter, left centimeter, numerous anechoic cyst of varying sizes in the cortex and medulla bilaterally, some cyst in right kidney upper pole, so echogenic contents with probe tenderness, anechoic cyst 2 to 3 with centimeter with size 2 to 3 with size of 0.5 to 3 centimeter, normal liver parenchyma, no cirrhosis, and pancreas showing no cystic lesions.
So what do you feel the diagnosis is? Is it acute pyelonephritis or is it cyst infection?
Sir, since there are echogenic contents are present in the right kidney upper pole with probe tenderness, so I would like to, sir, keep cyst infection as my differential, sir, more likely.
So how could the urine grow E. coli then? Cyst infection is usually loculated.
Yes, sir. Sir, if it would be communicating with the calicial system, then
Not very common, but
yes,
can happen.
yes,
With small ducts, they can communicate.
yes.
Okay, please proceed.
So initially, patient was managed with injection piperacillin tazobactam plus levoflox for 14 days, then followed by oral levoflox for 14 days. There was adequate hydration. The pain relief was given, bed rest along with salt restriction, and then further imaging was done, MRI, KOB followed by PET CT. So MRI KOB showing numerous varying size cortical as well as medullary cystic lesion in the both kidney, and the right kidney is 13.8 centimeter with a volume of 398 ml, and left kidney of 14.9 centimeter with a volume of 400 ml. So cysts are replacing the entire parenchyma homogeneously, hyper intense on T2 weighted. The largest is 37 ml. There is no perinephric fat standing is there.
Okay, tell me one thing. We did an ultrasound. It shows polycystic kidney disease. Okay.
Yes, sir.
So what are the various criteria diagnosing KD?
Sir, criteria, sir, based on ultrasound imaging, there is Ravin's criteria. So predominantly for the PKD2 phenotype, and there is Dimitri's criteria that is for PKD2 phenotype, and there is unified pi criteria right now that is being used for the diagnosis of PK.
Okay, what is that?
Sir, in which in these if there is patient is having a family history of polycystic kidney disease, and if the patient is of 15 to 30 years, then if the patient is having more than or more than or equal to 3 cysts total, then the patient is having autosomal dominant polycystic kidney disease. In age of 30 to 40 also they have taken the more than 3 cysts. In 40 to 60, sir, they have kept more than 2 cysts in each kidney, and in more than 60 years should be more than or equal to 4 cysts in each kidneys.
Okay, why this unified criteria has come into being?
Sir, a unified criteria has come into being to the increase the sensitivity, sir, because in initial Ravine's criteria, in the early age group, the sensitivity of detection was less, so that's why modified unified criteria has been.
And what is the MRI criteria for diagnosing ADPKD?
Sir, based on MRI, there should be more than 10 cysts in total in the age group of 16 to 40 years for detection of autosomal dominant polycystic kidney disease along with a family history.
Okay. Which modality of investigation is the best for diagnosing complications of ADPKD?
Sir, for diagnosing complications, sir,
Whether it's ultrasound or CT scan or MRI?
sir, MRI and CT scan has been shown to have similar.
Calcifications are best seen with?
Sir, CT scan.
Okay. And what about MRI?
Sir, MRI are sir, the cyst infection and hemorrhage use.
Okay. Remember that the best investigation modality is MRI because
Yes.
you can see the fluid levels, you can see the wall thickenings, you
Yes.
can see the septations very well.
Yes, sir.
You can see the nodules also and the compartments.
Yes.
Okay. Okay. Please proceed.
Sir. So this is the FDG PET imaging of the patient, showing FDG PET light up in the right upper to mid pole region with showing cyst infection with hemorrhage. So course in the hospital, he became afebrile in 5 days. Hematuria subsided, flank pain subsided in 9 days, and AKI start resolving by day 17. He was discharged on day 17, and on discharge advice, he was advised a period of convalescence of 4 weeks. So since he is a serving soldier, he was given sick leave for 4 weeks and then asked to follow up after that with advice of plenty of fluids, 2.5 to 3 liter, avoid salt, reduce weight, tell me certain 40 mg BD, and then after 4 weeks, review in OPD with CBC, KFT, electrolyte, urine routine, and culture.
Okay, tell me what are the treatment criteria? What are the treatment guidelines for managing a patient of ADPKD?
Sir, the treatment goals in patient of in patient of ADPKD. First, there would be sir adequate hydration to prevent new cyst growth, salt restriction, then sir weight reduction to maintain a BMI within normal range, BP control and to a lower level, and sir to prevent the progression of PKD disease with sir VAP10 sir.
Okay, what about other measures like smoking, taking
Smoke,
coffee,
yes, sir.
ketogenic diet?
Sir, smoking cessation is there, but there is no any need to cut down on caffeine intake in patient of ADPKD.
Okay, so why was this patient not started on tolvaptan on discharge?
Sir, initially the MRI was not done, sir, because the patient we didn't know the Mayo classification, and since the Mayo classification should be done at a stable state, so that's why, sir, the patient was not started on tolvaptan initially.
Okay, what is Mayo classification?
Sir, Mayo imaging classification is MRI based imaging classification of autosomal dominant polycystic kidney disease to look for based on the height adjusted total kidney volume to determine the risk of progression of the disease. So it's for a typical ADPKD, there is class 1A to 1E, and then sir for atypical kidney disease, there is class 2A and B.
And what about class 2B?
Class 2B, sir, is kidney disease. If there is a bilateral cystic disease with unilateral bilateral contracted kidney, sir.
Okay, what are the types of atypical ADPKDs you know of?
Sir, atypical ADPKD can be, sir, a unilateral when there is involvement of only one side of the kidney, and then second is a segmental, that is the only a part of kidney is showing cystic lesion. Then sir, asymmetric, that on one side there is predominant of the cyst and the other side there is might be a segmental or mild involvement is there, sir. And the other is loop sided, when there is more around 4 to 5 cyst shoot more than area.
Okay, so this is a cyst.
Sir.
How do you a cyst infection? Diagnose a cyst infection. Is there a diagnostic criteria for that?
Yes,
Or
sir.
is the algorithm for that?
Yes, sir. So cyst infection can be initially, first we will look at the sir, history, whether the clinical presentation of the patient. So patient with suspected cyst infection has generally fever, and along with that, sir, hematuria, flank pain would be there. And then, sir, there are three classical uh, categories, sir. Then of which there should be two manifestation in the two categories. So there should be presence of two manifestation on each of the two category. Then we will diagnose patient of cyst infection.
The categories are basically clinical factors,
Microbiology
and
and
imaging.
imaging. Yes, sir.
Okay, so please proceed. So do slightly fast because we are just overshooting the time.
Yes.
Yeah, I think we can
Yeah.
proceed
Sir.
fast.
Yes. So investigation and discharge of the hospital, the TLC was settled. The procal has become negative. Urine culture is sterile, and creatinine has came down to 1.6, sir. Then so the final diagnosis is ADPKD with right upper polar cyst hemorrhage with right upper polar cyst infection responded to antibiotic, hypertension, and AKD stage 1.
Why do you call it AKD?
Sir, because the renal dysfunction is present for more than 7 days and it has not reached up to 90 days, sir. So that's why we are keeping this as AKD, sir.
Are you aware about any the staging of AKDs?
Yes, sir. Sir, AKD staging can be 0A, 0B, 0C, and then as same as of AKI. In 0A, sir, the baseline creatinine settled to normal without any progressive renal dysfunction. In 0B, there is the creatinine has settled to normal, but there is a progressive renal dysfunction is there. And in class 0C, there is the creatinine has settled down to less than 1.5 times the normal, and there is progressive renal dysfunction. And 1 to 3 is same as of AKI, sir.
Okay. Now, move forward, please.
And then again readmitted on in October 2018 post convalescence. There was no any fresh hematuria, no pain abdomen except occasional heaviness in both flank. Bilateral one BP is, sir, 118/76. Height is 80 kg and he was placed in low medical category. Now the TLC is settled. The creatinine has came down to 1.2 and urine culture is sterile. So now further imaging was done for prognostication since now patient is relatively stable. So following imaging of USG KOB, MRI KOB and genetic analysis was done. So this is the height adjusted total kidney volume calculation based on the MRI imaging. So, and this is the genetic study of the patient showing heterozygous PKD1 mutation and with truncating mutations.
Okay. Is it patients to undergo genetic testing?
No,
Or
no,
there's
sir.
specific indication for genetic testing?
Sir, there are specific indication for genetic testing, sir. If the patient has a negative family history, then the patient has any atypical presentation as compared to other family members of having a similar illness. And third, sir, if we are taking at-risk patient for a potential donor candidate, sir. And then to enable selection of mutation-free embryo, we do pre-implantation genetic study of such patients, sir. And or if there is any atypical imaging presentation, even if patient is having family history on imaging, then we should do a genetic analysis instead.
Ravi, this patient is a classical patient
Yes,
with
sir.
a strong family history. Patient had cyst volume. One kidney was 400, you said, other was around 380.
Yes,
Total volume almost 780 or almost close to 800.
yes, sir.
Why you went for genetic study in this patient? You were very clear that this is a patient of ADPKD with a
Yes.
strong family history. What was the necessity? Now,
Sir, since
you have not mentioned that you are going for transplant or anybody is donating, the relation is donating, or you wanted to do for something, but you have done for the patient.
yes, sir.
Yeah.
Sir, since the patient has, sir, some atypical presentation as compared to the other family members, sir. Since
Well, what is
her
the atypical presentation?
Sir, since her grandmother died at the age of 68 and we didn't know the cause, and paternal uncle died at the age of 70. So generally, sir, this and also the father is alive at the age of 68 years and not dialysis dependent. So generally, sir, family history is not congruent with the PKD1 mutation. And since the patient has an early presentation and that the initial presentation was when 10 years back. So the family mm, um, history was non-congruent with the this patient presentation. That's why we go ahead with the genetic analysis.
Would this genetic analysis help in any prognostication?
Yes, sir. Sir, genetic based on the genetic analysis, if the patient is having the truncating mutation or if the patient is having PKD1 mutation, then the chances of progression to end-stage renal disease is, at an early age is higher, sir.
So you tell me,
What's that score? called?
What is this
Where
pro
genetic
PKD.
analysis?
PKD store?
Pro-PKD
Pro
store. Yeah,
PKD.
you have.
What is
What
this
are the
pro?
other characteristics of pro-PKD
Sir,
in addition to genetics?
sir, other characteristic is the sex of the patient. Male are known to be rapid progressor. Then, sir, early presentation of hypertension, that is less than 30 years. And,
Yes.
sir, any urological event at less than 35 years of age.
He has 9 out of 9 score.
Yes, sir.
Yeah.
Score is 9. 4 you give for genetics.
Sir.
I think 1 mark is for sex.
Yes, sir.
2 marks are
One for hypertension.
hypertension. And
then
less than
the
30.
urological
Higher than
event also.
35.
He's had a
Sir, 9,
urological event also. So he got all the scores.
He's
Yes,
got
sir.
all the score.
So, Dr. Ravi, would you like to do genetic testing and check for pro-PKD score, or would you be happy with prognosticating the patient on Mayo imaging classification only? Which is better, and what are the pros and cons?
Sir, pro PKD score, sir, have the additional genetic information, sir. So it's a better for prognosticating the patient as compared to Mayo class 1, Mayo classification.
I'll put it the other way. You have Mayo imaging classification. You can do it yearly MRIs, and you can tell the patient that yes, this is going on, and then medicines can be added, and then you can see for the the control of the cyst size as well as stabilization of EGFR. So pro PKD score might underestimate
Yes, sir.
the disease progression.
Yeah,
So
but if you are thinking of an atypical presentation, it's not fitting into that family kind of a history and as well, and you did the genetic test for that. So most of Mayo characterization is for a very typical score, basically typical presentation of ADPKD and all that. So they haven't included atypical PKD presentations in the Mayo Clinic as such. So it is true predominantly for typical presentations, and that's what is available. So there may be limitations. So each information might add on to some kind of information if both pro PKD study as well as the Mayo Clinic suggests that the patient is in 1C, 1ED, then obviously he is at a higher risk for progression. And this patient, at least the pro PKD score does suggest, and I think his volume status also suggests that he is at a high risk for progression.
Did you put him on tolvaptan?
Yes, sir. After we have done MRI, and then after that we have started a patient on tolvaptan.
Sir, he was
I will
started on
discuss in
tolvaptan,
further side, sir.
but he did not take it, sir.
Yes.
For how many years he is already on tolvaptan?
Sir,
He didn't take it.
Initially,
He didn't
yes.
take it, sir.
He didn't take it.
He missed this history in the previous slide, sir. We started him on, he was very apprehensive, sir, in taking tolvaptan.
Yeah.
Okay.
So he says कि मेरा ये हो जाएगा वो हो जाएगा. So he asked him to 15 milligram BD ले ले, try it out. He did not take. Ravi tells the history.
Dr.
Yes.
Ravi,
Yeah, I think मेरे ख्याल में you have to go 725. So
Sir.
just one
done.
question.
Gone.
Mr. Kher, just one question. Talking about getting an MRI Vaptan, is it essential? If so, why?
Since as a tolvaptan, we generally tend to give in the high risk group, that is 1C to 1E group. So that's why, sir, we want to get an MRI done before starting the patient.
If you give it in the lesser groups, then will it produce any harm?
Sir, but sir, it's the risk benefit ratio of the tolvaptan is there, sir. So there would be an associated hypernatremia and chances of liver dysfunction is there. So that's why we.
Yeah, there is no good evidence to show that. The two studies which were done, both Tempo as well as Reprise studies, were done in people who were at high risk for development of progression. So that's why you don't have data on lower risk as such, large randomized data on lower risk patients. So usually given at the moment in high risk patients. So
Yeah,
Since
so
you don't have risk
do it,
benefit
do an
ratios in a
MRI
randomized trial,
before.
that's why you don't do it.
Yes, sir.
That should be the answer.
Yes.
Suppose you do ultrasound and the kidney size is more than 16.5 centimeters.
Yeah.
Are you safe in giving tolvaptan, or you still would like to go with MRI?
Sir, if the kidney size is more than 16.5 centimeter, most likely, so height we will look at the height. If the height is on the lower side, most likely, sir, it's a high risk group only, sir. So we can start in such patient.
We should.
They should. And in Tempo trial, what was the average kidney volume?
Sir, it was 800 something. I didn't remember the exact figures.
If I have not gone through this, Manu, I think it was 650 ml?
750.
750. So this patient already classified.
Yes, sir.
800. His
No, I
volume
think he fits in with all
fits
this
everywhere.
calculated in
Yeah.
any of
Truncated
the.
mutation, rapid course.
Yeah.
Ravi,
He
please
fits
proceed.
in.
You'll see, sir, the presentation further, sir.
There's further presentation.
Sir. Ravi, just rush through.
Can you just run through?
Run
Yes, sir.
through.
In between 2018 to 2020, sir, he had intermittent hematuria but not needing admission. Creatinine was mildly elevated in each episode but
Yeah,
stabilized.
carry on fast. Yeah.
Yes,
Next.
sir. So creatinine was settled on 1.3 and hemoglobin was 13.5. He had yearly MRI imaging during mandate review, but patient did not take tolvaptan initially. And then in March 2020, at the age of 37 year, on routine follow-up, the MRI was done showing progression from Mayo classification 1C to 1D, and he did not take tolvaptan. There was also fall in EGFR. Then again counseled, and he was restarted on tolvaptan 45 mg and 15 mg, and telmisartan was continued. Then in March 2020 to 2022, he was asymptomatic. There was no any admission with UTI or hematuria. Renal function was stable, creatinine static around 1.3 to 1.5. MRI showed stable kidney side and height adjusted total kidney volume remained static on tolvaptan. And tolvaptan was increased up to 90 mg and 30 mg. And then patient felt uncomfortable. So it was decreased to 60 mg and 30 mg. And on investigation, sir, the creatinine was settled static around 1.4 and 1.5, and there was progressive rise in height adjusted total kidney volume from 778 to 810, sir. So this is the CT scan of in between events where the patient presented with an episode of nephrolithiasis.
Proceed.
So multiple admission in 2023
Just go back. Go back on 2 slides. Just go back. Go back. Go back.
Sir,
One more slide.
Stuck, sir.
Yeah, the next slide. Yeah, here you have given cyst volume 778, 800, 810.
Yes.
So this increase is only 1%.
Yes.
800 to 810.
Yes.
Is it tolvaptan?
With tolvaptan.
This is remarkable. 70. This is just 2%, 2.3.
It is actually.
Yeah, that is, yeah. This is what I wanted to emphasize, that if he is on tolvaptan, look at the cyst volume increase. You are checking it. Go ahead.
Go ahead. Next. Yeah.
Then inside 2023, at multiple admission with fever and left flank pain, there was gradual rise in creatinine and tolvaptan was stopped. And in Jan 2023, he had presented with episode of fever and there was leukocytosis with a TLC of 16,000. There was rise in creatinine up to 2.2 and urine culture. And 23, he had again rise in creatinine. Height adjusted MRI was progression of the disease. Classification height adjusted total kidney 2023 had a culture showing event was on the higher side 4.3. So and to November 2025 he admitted with chills and rigors for 3 days. Flank pain with no incapacitation, urine output reduced over the loss of appetite and vomiting. And on examination, patient was no BP was 88 by pulse was 124 per minute and was unable to maintain saturation on room air and had 100% of saturation on oxygen by face mask at 6 liter. Chest showed bilateral coarse crackles, and focus there was bilateral B lines and enlarged bilateral kidneys, and there was left flank tenderness. So on anemia with HB of 7.5, leukocytosis with predominant polymorph, and creatinine has gone up to 8.8. There was severe electrolyte dysfunction with sodium 149 and potassium of 6.45. Procal was on the highest side, and urine routines of numerous RBC and 10 WBC, albumin 1 was bicarbonate was 13, and there was severe metabolic acidosis. Urine culture so Klebsiella with sensitive to cholesterol, gentamicin, and Septran, and ultrasound QB done. So left kidney 18.6 centimeter and right kidney 19.5 centimeter with left up showing debris, and there was probe tenderness. So this was a PET scan and showing a light up in the right bulky right kidney with a light up in the right upper
Bulky left kidney.
left
It's
kidney
bulky left
sorry.
kidney.
Sir, bulky left kidney with FDG light up in the upper pool.
Next.
So he was admitted in view of sepsis, was admitted in ICU, started on injection cholesterol and injection cefepime. SLED was done, had persisting shock needing dual vasopressors, and initiated on CRRT with Oxeris. Mechanical ventilation was given, and patient, there was persistent septic shock was there. So that was done on 20th September. And the
Initially
patient,
fecal
yes, initial sir was tried, but still the patient continued to have shock. There was a requirement of inotrope support, and so the patient was taken up for left nephrectomy on 20 September 2025. So initial cultures, blood cultures were also saying Klebsiella pneumonia sensitive to cholesterol, and repeat cultures were sterile, and Procal was settled to 0.5, and but the creatinine continued to be on the higher side, that is 6.7, sir. So discharge on 10th November and dialysis dependent on SD, and then left radiocephalic AV fistula was created on 8 November 2020. Right tunnel cuffed catheter, and sir, now counseled for kidney transplant.
Still finish the.
No, I think he has highlighted a very interesting case where patient has suffered from multiple cyst infections, and the hospital had the facility to do PET-CT, which as on today remains the best modality for diagnosing cyst infection. Short of that, one can certainly go for MRI, or the facility may not be available everywhere. It may not be affordable. So short of that, one can go for MRI or CT. But if possible, yes, PET-CT is for diagnostic purposes. And once you are fed up with that, I think nephrectomy, there is no option but to go for nephrectomy. And the case also highlights that in this progressive disease, though the patient was not willing to take it, but possibly whatever you showed for 2-3 years, what it took tolvaptan, there appeared to be a benefit. He had stopped the progression of size of the. I think asking different why this high dose was small dose. Discussion on the dosage also to Khullar finished. Professor.
Yeah, please.
Well, thank you very much. Thank you very much for the opportunity. Start right now.
Prakash, you.
Okay, I'm sorry. I'll have to do it again. So let me. There was an overlap between the Ravis and this thing. I'll just be back.
I must convey to Ram Prakash meanwhile that he has got compliments from one of the audience. Dr. Ravi has presented the case and discussed very well, calm, composed, and confident. Well done. I think that's a compliment to you, Ram Prakash.
Ravi Prakash.
Ravi, sorry.
General Verma, are my slides visible?
Yes, yes,
Yeah,
yes.
please. Yeah.
So I'll thank you once again, and I'm going to over the next time General Verma allots me now the truncated time. So I will abide by that and quickly rush through many of my slides as they've already been discussed. Well, you see, we all know that, and I think I'll which are absolutely basic, and just to sensitize everyone to the fact that we are talking about the fourth leading global cause for kidney failure, and certainly the commonest hereditary disorder which we as nephrologists come across, incidence being anywhere between 1:400 to 1:1000. And we know the relative importance of the various mutations. PKD1 acting via the polycystin-1 pathway is the commonest, accounts for good about 85% of the cases, while PKD2 initially was thought to account for the remaining ones, but now we have realized that there are many more entities which you are probably not aware of, and we have certainly been sensitized to the fact that there's an entity called NAB, and we also know the way we were looking at fibrillary nephritis via DNAJB9, we know that we should be looking at towards polycystic kidney disease also via another similar heat shock protein, that's DNAJB11. And certainly, thankfully, there are not too many beyond PKD1 which we have to master, but then certainly the fact remains that we may know just about 92% of the total volume of the problem, and we still are not very familiar with the remaining few, about 8 to 10%. Well, talking first about PKD1, we know the mutation is on the chromosome 16, the short term of chromosome 16, the 3 hypervariable region of the alpha globin chain, and now we have localized it more to 13.3, 13.1. And on the other hand, the mutation for the PKD2 has been found to be the long arm of chromosome 4, 21, and 22. Well, brief about pathogenesis, and this is something I think we need to now change our perception about how to tackle. And I'll spend a few minutes towards the end of my presentation talking about just from where I'm actually beginning. And this is the pathogenesis. And as you can see here, and let me try to get hold of a pointer here. Well, so as you can see here, it's basically a ciliopathy, and where the gene, which is PKD1 or be it PKD2, is ultimately going to translate into something happening to the polycystin-1 or polycystin-2, which are the proteins which these genes make. Well, in the way we have realized the relative importance of few of the things, especially related to endoplasmic reticulum or the Golgi bodies. Well, the N-linked glycosylation, as I talked about the newer concepts linked with GANAB or DNAJB11 or ALG8, etc. So what typically happens, as you can see here on the right panel, is normally the vasopressin, which we know is there, acts via the vasopressin 2 receptors and will have its action via adenylyl cyclase 6. And now this is going to convert ATP into CMP, and a cascade of events get started, the phosphokinase A, and now there is an interplay between this as well as the mutation activated protein kinase, the mammalian, the mTOR pathway, or the wingless integrated pathway, and of course the signal transducer, the STAT3 as well. But thankfully, it doesn't happen, because if this were to go on unchecked, it'll cause fluid secretion, it'll cause the expansion via the cystic fibrosis transmembrane regulatory conductance regulator, which will force a lot of chloride into the cells, and subsequently something bad will happen. So why does it not happen normally? There are the somatostatin analogs, and there is this intracytoplasmic cytosolic calcium, which does not allow the adenyl cyclase AC6 to act. And the problem arises when this calcium is not there. And where does this calcium go? This happens when we have a mutation, when there is absence or there is a decreased function of polycystin 1 or polycystin 2. The control over calcium is gone. So this is not there. The calcium gets reduced, and now there is not enough scope for blocking this pathway. And ultimately, at the level of the CFTR, as you can see here, there is more and more chloride accumulation. And I'll summarize it into one more time. With the loss of ciliary function in PC1 and PC2, there is a reduced intracellular calcium. There is an increase as a result of adenylyl cyclase activity, increased cyclic AMP. So everything is going to remain dependent on cyclic AMP. We have been talking a lot about tolvaptan. This is where it acts. And of course, it promotes protein kinase A activity. And as I'd shown, the CFTR driven chloride accumulation. Well, on the face, been knowing that ADPKD is an autosomal dominant, as the name suggests, but there is to it. When you carefully look into it, we know the difference between autosomal dominant and recessive. Well, the analysis of the cells lining the cyst in a typical patient with ADPKD revealed that these cells lost the second normal, apparently normal PKD1 allele, in addition to the germline PKD mutation. You already had one allele affected. Now, if you have a second hit given to these patients, the second allele, the normal looking allele, will also get affected. So making it a situation akin to autosomal recessive. So it suggests that although inherited, ADPKD, it is inherited in an autosomal dominant fashion, it at the cellular level by a recessive disease, which is caused by a double hit. So that's something which we always need to remember. We have been told about the Mayo classification. Before that, what do the kidneys look like? We know the huge kidneys we all encounter sometimes actually take accounting for the entire abdominal length and breadth. And we also have, as we were mentioning, the atypical ADPKD, where it could be either unilateral, as you can see, unilateral, but some slight one or two cysts present on the contralateral side as well. A segmental, where it involves one pole or both the poles. I'm sorry, I just need to connect my charger. Just give me a minute. Yes. Okay. So as you can see here, so these are the varied presentations which we all encounter, and including the fact that there could be bilateral presentation whereby there could be one acquired unilateral atrophy, as you can see here, or it could be bilateral atrophy. So you can actually encounter all sorts of these entities before labeling them, as we were hearing, as autosomal dominant tubulointerstitial disease, ADTKD. We will need to really carefully analyze, and that's the beauty and that's the importance of genetic analysis. And we need to relook at the importance of genetic analysis in 2025 very differently from what we were doing till about a decade ago, or definitely even longer than that, because the facilities were not available. Our understanding was not as much. Well, clinical manifestations we've all heard about today. We typically saw a case. We saw a case of typical infections, recurrent infections, where ultimately patient had the nephrectomy had to be done. These are the whole lot of other renal manifestations starting from the pain, and we know the pain could be because of the cyst enlargement, cyst hemorrhage, cyst infection, stones in the cyst, whole lot of causes. And then equally important are the various other things that have been shown in this. But equally important for us as nephrologists is to account for the extrarenal manifestation, especially the dreaded ones like intracranial aneurysms, the pancreatic cysts, the hypertension, of course, is very, very common accompaniment. Hepatic cysts, well, you have to view it in two different scenarios. One is a typical patient of autosomal dominant polycystic kidney disease who also has a hepatic cyst. But thankfully, the liver function doesn't give you much of troubles. But so many times, and very thankfully, very rarely, the cyst size can be so huge that even without a loss of the synthetic liver function, you can be in deep trouble going by this sheer magnitude of the problem as far as the liver cyst size is concerned. But then equally other entity is where you have autosomal dominant polycystic liver disease, ADPLD as is caused, whereby the kidney involvement may not be as significant and the patients may just have a predominant liver disease. Well, we also do need to keep in mind that there could be hernias, and Dr. Ravi Prakash had, when he was talking about the abdominal examination, we should also mention about the various hernial sites, because that's a big problem. And also, if you were to try and tackle them surgically, there could be very high chances of recurrence. Male infertility, and especially because of at times the involvement of seminal vesicles, the epididymal cysts, although they don't cause infertility very commonly, but then cases are there. And of course, the valvular heart disease, typically the mitral valve prolapse, the aortic regurgitation, and less commonly the mitral regurgitation and the tricuspid regurgitation. Why is hypertension so common? It's because of the compression of the renal vasculature caused by the increasing size of the cysts. It's renin-mediated dependent, and you have an increased sympathetic activity. So certainly there is a big role to play by the RAS inhibitors when we are looking at hypertension in a patient with autosomal dominant kidney disease. Well, as you can see on the left-hand side, this is what happens when they attain end-stage kidney disease. But then equally important is the effect on the endothelial function. The endothelial dysfunction can, via reduction in the nitric oxide or increase in the endothelin, can play havoc with the vasculature across the entire body, and you can expect aneurysms, dissections, and other vascular abnormalities as well, besides the left ventricular hypertrophy and ischemic cardiomyopathy as well. Why is the pain there? We know that the pain, these are the various causes. And hematuria, again, the important thing to remember is those people who have recurrent episodes of gross hematuria and have very large kidneys tend to progress more quickly to renal failure, especially if, as we know, based on pro-PKD score, the urological problems happen before the age of 35. We have heard a lot about. I will not go into the details since majority of the points have been very nicely covered. And I think just to remind everyone that we need to differentiate between a typical cyst infection, a parenchymal infection, a person who may be harboring polycystic kidney disease has all the chances of having parenchymal infection. But when it comes to cyst infection, as was highlighted by General Verma, you may expect positive blood cultures rather than urine cultures, unless, as Dr. Manu pointed out, there's a communication between the cyst and the collecting system. And of course, the presentations can be varied, and it can be a combination of the two. And the reason why we really want to differentiate is because the treatment expects us to target both the parenchymal infection as well as the cyst infection, because for the cyst infection, we need to give those antibiotics which actually can penetrate the cell membrane, the lipid soluble, etc., especially the quinolones or carbapenems, as compared to the parenchymal infection, which can be taken care of by most of the commonly used, because it's an E. coli in majority of the cases. Well, nephrolithiasis, we know that there's a high chances, especially of the uric acid stones. More than 50% of the stones we encountered in polycystic kidney disease are uric acid, and these are the few of the predisposing factors such as hypocitraturia and hyperoxaluria, etc. And we need to take care of the low urinary pH which these patients may have. Now, there are a few philosophical things attached to when we look at what happens to these patients. People may argue that if one is going to be able to live to at least good 40, 50 years of life, even in the worst affected PKD1, or many of these, even the PKD1 can survive up to 60 to 70 years, especially females who we believe have extra about 5 to 6 years of renal life as compared to the male counterparts. So is there any point in terminating these kind of pregnancies? We can have some discussion if time permits, but yes, as I said earlier, a lot of philosophical thoughts behind it rather than pure science, because the way you look at a glass half full or glass half empty is what will typically come in handy here as well. But what we know for sure is if the total kidney volume is greater than that for the expected age, or if patient is obese, if hypertensive before the age of 35, and definitely difficult to control blood pressure, is there's a proteinuria. And I'll come back to that proteinuria, very pertinent point raised by Professor Amit Gupta. And of course, the urological events happening before 35 years of age. And to top it all, the time, whether there is a PKD1 or PKD2 mutation. If it is PKD1, is it truncating or non-truncating? Well, just a brief about polycystic liver disease. The liver people had become quite excited about the usage of somatic analogs, and they were at some point in time also trying to influence us as nephrologists to try the drugs which they found were useful in liver disease. Well, the answer is they don't help in the ADPKD. For the liver patients, no specific diets are available, and then thankfully, majority of the times, the synthetic function is not lost. But by the sheer size of the liver, there could be an associated sarcopenia, and we need to look at sarcopenia or malnutrition in these patients. We can do that by SMI, which is the skeletal muscle index, which in females is there if the SMI is less than 38.5 than 52. Similarly, with the use of the BCM machine, you can see whether your patient has significant sarcopenia, which means if the female has it less than 5.7 or a male has it less than 7. So it's extremely important not to allow your patients to become that malnourished or sarcopenic before you realize you are late. This again is important because so many times, even though the liver failure may not be there, but the size may compel you to go in for a liver transplantation. And at that point in time, if the patient has a significant deterioration of the GFR, so many times the way forward would be a combined kidney and liver transplantation. We've had our own experience as far as this is concerned, very few gratifying results. But as I said earlier, it's not very often that you come across such an entity. Well, I've talked about the fertility of stomatostatin analogs in patients with ADPKD. Well, the aneurysm is something very important, which we tend to forget. We all know about it, the way we all are fully aware of the relative importance of vaccination in our CKD population. The same holds true for intracranial aneurysm. Everyone, I'm sure, today knows that there is a higher incidence of intracranial aneurysms, and look at the implications. If you were to look at the general population, the prevalence of intracranial aneurysm is just about close to 3%. And the same people, if they have a family history, it increases to about 3.5 times a higher risk. But when it comes to ADPKD, look at what we are talking about. 13% if patient has polycystic kidney disease, there are going to be the chances of him or her having intracranial aneurysm. But if there is a positive family history, and this is something which we can't ever afford to miss, there is a family history subarachnoid hemorrhage in a family of or autosomal dominant PKD. We certainly must always get these people screened for intracranial aneurysms, because there are definitely very high chances of subrecurrent hemorrhage. If the normal incidence in general population is just 0.08, it becomes higher in the same people if they were to have some family history of subrecurrent hemorrhage. But look at what happens when the patient of polycystic kidney disease is there in front of you. Look at the high chances of him or her having subrecurrent hemorrhage. And if there is a positive family history, it's definitely going to be much higher. We do not have the exact data, but then everyone does know for sure that's very, very high. And you can't afford to allow your patient to go into that kind of situation, because this is preventable, and you should always try to look for and educate your people about what thunderclap headache is, because they will say, this is the worst headache in my life. This strikes suddenly like a bolt from the blue, and it's a lightning, and it reaches maximal intensity within 60 seconds. And even though we know that we are late, and I think we should take care of whatever precious time we have in hand and immediately shift the patient for higher management. Well, these are the advantages and limitations for screening these patients. I think I have sensitized everyone to the fact that we should all be very proactive in screening for ICS. So talking about abdominal hernia, now again, there are very high chances, and we generally resort to non-surgical management. So these are the guidelines which were published earlier this year, KDIGO 2025 guidelines. So majority of the take-home messages which I have for you all today are straight from the KDIGO guidelines. Well, they also say that generally you should resort to non-surgical managements, because there is a very high chance of recurrence hernia, and you should do it only if there's a strong reason. And especially you should educate the people that as to what hernia incarceration or strangulation is all about, so that they can immediately report to you should they find themselves in a situation like this. And of course, we at times do have to go in for repair of these hernias, especially people who elect PD. And then, mind you, very important message which I am going to share today is PD is not a no as far as managing end-stage kidney disease secondary to ADPKD is concerned. You can certainly have the same kind of enthusiasm with PD as you can have in all other patients whom you treat for CKD and end-stage kidney disease. But if you were to pick up these patients, it will be important to take care of these hernias before you go in for that. Well, now this is imaging, and this is something extremely important for all of us to remember every time. This is again from the guidelines, which say that look at the two scenarios. On the top is when you have to diagnose, and the lower panel says when you want to convincingly, because he wants to be donating the kith or kin. Now the dilemma, what do you do? So first, when you know the case of ADPKD, you have divided it into three different well, thank you very much. Well, the age is between 15 to 40 years. You have to have an evidence of cysts, both kidneys put together, to have a positive predictive value hitting 100%. And when it is between 40 and 59, there should be 2 cysts in both the kidneys, 2 or more cysts in both the kidneys. A person over the age of 60 should be more than 4 cysts in both the kidneys. Very high sensitivity, which means if you have 4 cysts in both the kidneys, I can actually label it as polycystic kidney disease in a person where there is a positive. This is extremely important. In a person where there is a positive family history and you want to know for ADPKD is not there, then even a presence of a single cyst will exclude will be very taken very seriously, because if there is more than one cyst, right, so you can exclude the predictive value based on a negative test, which means that there should not be even a single cyst for you to have a negative predictive value of 99% and a specificity of 98%. So as you can see here, the difference between the two would be the sensitivity and the specificity. Similarly, between 40 and 59, there should not be even a second cyst, which means two or more cysts will confirm. So you have to have less than two cysts, or again, maximum is one cyst which is allowed here. So this is extremely important, and whenever in doubt, we know that it's a very big responsibility on our shoulders. We will definitely want to go in for a genetic testing before accepting these patients. But this is the ultrasound criteria. And equally important is what we have learned over the years out of MRI. And MRI tells you that in a patient with positive family history, again, you have to have more than 10 cysts total to label it as a case of polycystic kidney disease. And if you find fewer than 5 cysts in total, then you can safely exclude the diagnosis of ADPKD between the age of 16 and 40 in people who have a positive family history. So with this in mind, what are the indications for the genetic testing? Well, if there is a no apparent family history, there is an atypical imaging pattern, there is an intrafamilial phenotype, discordance between the kidney size and function, which puts you in a kind of tight situation or a dilemma, and a severe and presentation seen in early age groups, or various syndromic presentations, like that autosomal dominant polycystic kidney disease type 1 on the chromosome 16 is right next to the gene for tuberous sclerosis, and there's an entity, as we all know, called contiguous gene syndrome, whereby there could be a combination of the two. So when you have a whole lot of presentations, I've deliberately not gone into them, but when it comes to so many cystic disorders which may not actually be ADPKDs, but could be a whole lot of others. And whenever in doubt, you must go in for whole exome. Well, Dr. Amit Gupta raised a very important point. We have personal experience here as well, where a very heavy proteinuria will certainly teach you away from ADPKD, because you don't expect ordinarily a proteinuria of more than 1 gram in people typically with ADPKD. We have gone ahead and done biopsies in not one or two, maybe in 3 patients, where it was the exercise was quite gratifying, because we encountered one membranous nephropathy, one FSGS, and one amyloid patient in these people whom otherwise were labeled as ADPKD. But what alerted us to the possibility of something additional was the heavy proteinuria. Equally important is when you look at the active urinary sediment, you have known this is not the RBCs related to infection or hemorrhage. And when you encounter dysmorphic RBCs or RBC cast, I think you should be alert. And it's an art actually, but again, you have to be very vigilant and careful. You have to try to find the area. If it is possible, you can take the help of your interventional radiologist to make sure that you have access to the renal parenchyma, and we could actually do that quite successfully in few of our patients. Well, we have talked in some details about the role played by the Mayo classification, and I think the trying to set the controversy at rest, I think I would say that we'll rather go by to get started, we should take the help of Mayo classification to broadly categorize. Now, this only takes into account the height-adjusted total kidney volume, nothing else, as is the case with pro-PKD. So, in the Mayo classification, all that you have to see is the relative risk. We know that class 1, class A and class B patients are comfortably placed. You don't fear a very rapid downhill course in them, while D and E are the worst affected, and you will not hesitate in treating and being more energetic in treating. C is somewhere in between. Also, your tendency should be more to treat these patients as well, and especially when they have some additional reason for you to be compelled to treat these patients as well. So the answer is very clear. In class A, where the relative growth is going to be less than 1.5% on a yearly basis, you should not be treating. You again should not be treating class B, but then be a little more careful as to what happens to their progression over the next. Maybe you may want to get another MRI done within a year, couple of years. But if the patient has C, D, E, definitely D or E, and in E where the rate of progression is more than 6%, you definitely should be treating them. As you can see here, this is the estimated EFR slope in these patients. Hardly much in class 1A, but look at quite impressive decline which you can expect in patients with class 1E. And this is the prognosis typically, as you can see on estimated various classes starting from 1A to 1E, and especially what happens to the GFR, as you can see in this panel. Well, PKD additionally, as we were told, takes into account the gender, the urological events in a person less than 35 years age, and also need for antihypertensive again in a patient younger than 35 years of age, and give a lot of importance to the genetic status. So maybe you can subsequently go in for pro-PKD. But mind you, the caution here is it may confuse you a bit in younger people. So especially if the patient is over the age of 35, maybe pro-PKD prognostic scoring can help you take a wise decision when it comes to therapy with sulbaptan. So management, we can't go away from the fact that it is lifestyle modification is equally important to them as well. I was very jealous seeing General Verma sipping his cup of tea, because there was one point in time where we used to tell these people not to take high doses of caffeine. But now there's enough literature which says that may not be the case. You can comfortably allow these patients to have their share of caffeine. General Verma, that was for you. So blood pressure reduction is equally important, and of course pain management, and of course the treatment with sulbaptan typically starts once between the age of 18 and 55, and you can go up to 60 years of age, as you can see here. And then there are endpoints to the. So talking first guidelines, as you can see, thing is to try their urine 2.5. Typically, we ask the patients to consume at least 3 to 3.5 liters. Even the KDIGO guidelines say that more than 2 liters. But I, on a personal level, would be keen on giving these patients, advising these patients to consume at least 3 liters plus of liquids on a daily basis. I would think otherwise only if the patient's GFR has fallen to less than 30. And this is basically in an endeavor and trying to bring down the typically to less. And the guidelines also talk about less than 280. Well, salt restriction, protein restriction, we are all very familiar with. The general guidelines hold true here as well. And we cannot move away from the role played by RAS inhibitors. And of course, maybe in times to come, we are going to come across some role played by the endocrine A receptor antagonists with or without combination of ARBs, and some word about FGF23 as well. So FGF23 again, we had a few things, molecules in mind. We got a lot of information via what FGF23 has to, the role which it has to play in the X-linked hypophosphatemic rickets. We had the impressive data with brusumab there, but there are trials which are underway which talk about pemigatinib and the another one is infigratinib, which have shown some early promise. But then at least we will be moving forward where the life has become almost stagnant with tolvaptan for almost over 2 decades now. So the medical management now, tolvaptan certainly is the only thing which we can actually offer to patients who are less than 55 years of age with a GFR of over 25. And certainly we have to be very, very sure as to which all patients are we using it. Typically the type 1 ADPKD patients where you have a rapid downhill course and you are going to be guided by the Mayo classification. Type 1, class 1D and E are definitely yes. When it comes to 1C, you have to have some additional evidence of rapid disease progression. Well, how to typically use? Now, literature may say something else, while our personal experience is totally different. The Western literature says that try to go up to 120 milligrams after starting at 60 milligrams. Now, we struggle to go up to that higher dose. We typically start with something like 30 milligrams. And please remember to have 2/3 of the dose in the morning and then the 8 hours later to give the evening dose, which is 1/3 of the morning dose. And this is how we begin. Typically 15 milligrams to begin with, then 30 plus 15, then 45 plus 15. And then at the personal level, I'm sure I would love to hear from Professor Kher, Professor Guptas, and everyone here in the senior people who have joined today to share their experiences as well. I personally have not been able to use even go beyond 90 milligrams. That probably would be the maximum I personally would have. And what do you have in mind? Basically, you want to keep the urine osmolality to less than 270 and as close to 200, I would say, would be a practical tip. So you combine the two. You combine whereby you give them a very high liquid intake, which suppresses vasopressin. But then on the other hand, tolvaptan, which actually acts at the level of CAMP. So the upstream, the vasopressin actually is going to go high. But you don't have to combine the two. They are independent of each other. So you can't say that, okay, you want to advocate 4 liters of intake to your patient so that they may not require tolvaptan. That is not true. So you have to keep them as separate entities. Well, whole lot of discussion around their hepatotoxicity. If I am not saying it is not there, so you have to be little wary of the potential of hepatotoxicity, but then it's not really too much. But that doesn't absolve you of your responsibility of getting the LFTs done, at least on a monthly basis for the first 1 month. People even advocate twice a month for the first 1 month and then monthly. But even after 18 months, you have your responsibility to check the LFTs once in 3 months. Supposing they go and rise up to 2 times, you just have to interrupt. And unless they rise to more than 3 times, you don't need to panic, because majority of the times, the moment you stop, there is going to be a decline in GFR, in the liver enzymes. And in case they do not come back to the normal baseline, you will have to consult the gastroenterologist colleagues. Well, it's not easy. It's not a straightforward, easy decision to talk only about the benefits of tolvaptan. You have to be equally mindful of the harms. And then there are uncertainties, whether it can really delay onset of kidney failure, because all that we know is certainly decreases slows down the progression of the total kidney volume. But whether
a small request, if we can wind up in next 3-4
we've already discussed, and I think I would rather go to something which I believe is more interesting. We have discussed UTI. I will skip that, and gout also is very important because clinical gout is identified in almost 1/4 of these patients with ADPKD, whereas in general population it is just about 1 to 5%. But again, as is the case, otherwise you don't have to treat asymptomatic hyperuricemia. However, the treatment in some patients with mild renal insufficiency has been found to attenuate. The gout treatment is again the same. You have to rely on drugs like allopurinol. Well, the few things which we don't have much evidence on. One is mTOR inhibitors. I think we should not be talking about the potential usefulness of this. They have not lived up to the promise. So have the statins. They are not going to be advocated for the use in ADPKD. But the interesting thing is about metformin. Metformin, people thought it acts via the pathway of the AMP, and probably will have some role to play. There were some trials. There were some data on metformin, which said that I think it was TAME PKD, which said that maybe it is useful. That we are looking at, but we have some data from PGI Chandigarh as well. Dr. Vivek was doing a lot of work on this, and I think what they inferred in this article published in Indian Journal of Nephrology was that metformin appears to be safe and well tolerated in non-diabetic patients with ADPKD. Well, these patients had their share of some GI disturbances, etc., etc. But then whether they are going to be useful in the long run, because ultimately this was just a 6 months trial, and then we will need more data, as has been shown in the other one, in this published in Biomedicines, whereby the Chinese group showed that the metformin usage in real world, showed lower hazards of end-stage kidney disease and MACE in patients with ADPKD, except for those who already have advanced CKD. So, well, this is about metformin. But another controversial thing is SGLT2 inhibitors. KDIGO guidelines say that they should not be used. But maybe it's too premature to give a final opinion, because maybe the data had not accumulated at the time of these guidelines. We just now have begun realizing that why deprive these patients of SGLT2 inhibition? Well, on the left-hand side in the blue, you can see there are the potential beneficial effects in ADPKD via the natriuresis, the glycosuria, the induction of mild ketoacidosis, etc., and finally leading on to reduction in cystogenesis and interstitial fibrosis. But you have to be equally mindful of the fact that there could be higher risk of cyst infections. The most equally important is the fact that SGLT2 inhibitors are going to cause an increase in vasopressin release. So on one hand, you're wanting to reduce, and they are going to probably play against each other, and then this could undo the potential effects. But then this is not the time when we will say that whether they may prove to be useful or not. At the moment, KDIGO says don't use them. This thing, and I think I'll skip a few. The pregnancy would be a very challenging thing in these patients. For the paucity of time, I'm going to skip, because I think the important would be one last, General Verma, just a couple of moments closer. I thought that's going to be important. The transplantation, again, we know at times we have to take a decision whether to go ahead with native kidney nephrectomy. So these are the indications where you may have to resort to a nephrectomy, especially recurrent infections, symptomatic nephrolithiasis, recurrent bleedings, intractable pain, suspicion of kidney cancer, which thankfully happens not very commonly. Insufficient space for insertion of a kidney graft is at times a decision which surgeons take very conscientiously. Ventral hernia in the setting of massively enlarged kidneys and so forth. So PD, again, as I said at the outset, should not be discouraged. There are enough data which says that PD can also be considered. Well, if tolvaptan has hepatotoxicity, people are trying to look at another one, lixivaptan, which has lesser hepatotoxicity, while bardoxolone, as was the case in Alport, again was found not to be useful. When Glucet, also the trial was terminated. So coming finally to, so far, all our efforts, after knowing so much about ADPKD, has been a sort of a defeatist attitude. We only have tolvaptan, and we are trying to find ways when not to use a drug. So same holds true as you had heard about metformin or SGLT2 inhibitors. So what should actually be the way forward? We have known that there is a genetic defect. Why not take care of the genetic defect itself? And how can we do that? We can. And I'll go slow now with of course, General Verma's permission. Replacement therapy, whereby...
I'll request you to wind up in 2 minutes, because Dr.
Okay.
Amit Gupta also has to
Okay,
give
sir.
his
So,
expert.
it's a renal replacement. It's a replacement therapy whereby you insert healthy genes. You have a knockout therapy where you knock out the genes that cause disease. You repair therapy by correction of the gene mutation. You enhance the therapy by boosting the cellular functions, or you interfere with the RNAs. And I think with that in mind, let's look at a few of them. As you can see here, our purpose is to take care of microRNA 17, and by giving them the antisense oligonucleotide therapy, you can precisely do that, whereby you may find no protein synthesis or altered protein synthesis. We typically take the help of viral adenoviral vectors, whereby they can go up to the level of advanced glycation end products and inhibit the cystogenesis in ADPKD. Well, the gene enhancement can be actually tried. This is what whole world is trying to do at the moment. And finally, curing ADPKD by spontaneous gene repair behavior. So this is something which is, I would say, around the corner. People are actually spending a lot of time and effort on that. And coming to my favorite, and my favorite is the CRESP R, where you know the Cas9, the CRISP associated protein 9 therapy in PKD is a wonderful thing. And just to remind everyone, the 2020 Nobel Prize went to the Jeanette and the Charpentier for their work on CRISP R Cas9 therapy. Here, you actually identify the mutation, which we have done in the case of ADPKD. Now, you have a guiding RNA which is combined with Cas9 and takes you to the faulty DNA sequence. And there is it's a micro scissor which cuts the abnormal thing and gives a scope for the DNA later on to correct the DNA, abnormal DNA later. So look at where we are trying to reach via CRISPR, and this is my personal favorite, and I'm hoping to see a lot of advancement in this area. And of course, the pre-implantation genetic testing also is something equally important, and possibly the way we are looking at the cancer patients, we also via the CAR-T, we can probably in future learn something about that. So just to conclude, this is what we have learned. I will not want to bore you again with what I've already said, but I will end by one more time reposing my optimism and my faith in what genetic gene therapy has to offer to us in times to come. And I think let us hope and pray that eventually that does happen and we are able to give something meaningful to our patients beyond what we have all been debating on, whether tolvaptan is effective or not, or whether increasing the water content. So this is something which I've discussed today, and this is sort of summarizes. And thank you very much for this wonderful opportunity once again. Thank you, General Verma,
Thank you very much, Professor Khullar, for an excellent and very exhaustive, I think, right from clinical spectrum to clinical manifestations. You have gone up to the gene therapy. I think a very exhaustive and excellent talk. I'll request Professor Amit Gupta, who is the expert today, to give his comments. Then we will have 2, 3 questions.
Good evening to all of you. I think the case presentation done by Dr. Ravi Prakash and ably guided by Dr. Manu Dogra was an excellent presentation, and it actually showed the wide spectrum and the progression of the disease. And of course, Dinesh did an excellent job of taking us through the pathophysiology, how to diagnose the progression of the disease, the various genetic studies involved, and the treatment. I have just one Khullar tolvaptan. This is a practical, and that said that the GFR is ml per. When do you stop it? How long tolvaptan? And do you stop it when the GFR drops to less than 25, or shall we continue further?
So 25 is just the beginning for a few patients, Professor. We can't afford to stop the moment it goes down to 24. So that's the key answer. So when do you stop? So answering your question, most of the people will stop when they start planning for renal replacement therapy. Personally, would till at least 15 ml of GFR in these, or else which stops me, like or hypernatremia, or the patient's life has become miserable with the kind of urinary symptoms.
Only problem, Dinesh, is that tolvaptan can cause some diuresis.
Yeah.
And it may hasten your decline of GFR in some of these patients.
Exactly,
So
sir.
that's one issue that you have. And many people do not want to start tolvaptan if your GFR is less than 25. And in fact, in some of our Indian patients, actually, they don't tolerate if the GFR is less than 30. So that if goes to less than very advanced kidney disease, because the likelihood of your progression will be faster.
So answering again, sir, I think we should go by the gravity of situation and be guided by the Mayo classification. If the patient has 1E and then already is deteriorating very fast, I will do whatever I can to at least slow down and wait for a few months. If there's a slowing down of the rate of progression and there are no untoward side effects with tolvaptan, I would probably continue. But I am with you, and I said earlier as well, Indian patients find it very difficult to tolerate the kind of dosages which have been really advocated. That's one. And secondly, we need to carefully follow them, and of course tell them that yes, there's going to be diuresis and there's going to be possible hypernatremia, and then they need to drink a lot of water and come back to you. And obviously the way we do it with RAS inhibition and with all other drugs, we just can't leave it into the patient's hands. And this is definitely a drug which has taken so many years to convince us that maybe it has a role to play. We were about its usage all these years between, I would say, 2010 and 2020. No many takers. Now that we have started,
just a
please.
couple of comment on that. One, we have to keep in mind that many times we advocate take a lot of water. Keep in mind, by you are only compromising with vasopressin. Vasopressin has got a very short half-life, if not seconds. So therefore, if you want to tell a person take plenty of water, he will have to keep drinking 24 hours, which is not possible. So let us not comment that take too much of water, because it is suppressing vasopressin, and the action of the suppression is only for few. I don't know exactly, but just 1 or 2 minutes only. Number two, if the situation is worse, it is always prudent to combine thiazide with tolvaptan, which causes the urine output becomes lesser, and that is one of the way to go about that. Third point, which has been discussed by the dose of tolvaptan, mind you, all the trial only, I don't see you, but they went up 20 milligrams. And why they have they kept increasing the dose, whatever, 60, 70, 90, 30, whatever, till the time patient was tolerating, and they went up to 120. Well, as you rightly said, Indian patients possibly don't tolerate that much. And if we go by osmolality, I also must remind you that there are no suggested that osmolality as a target. We are tempo trial, if you go to the supplement, you find that majority of the patient had osmolality below 200. And most of the patient had below 270 or 280. So practically, we also target 280. Whatever the reason may be, our Indian patient, we find that is very effective, and we are able to achieve the osmolality. As you rightly said, you have gone up to 9 of 6 patients, and we are achieving the, because many of are with 150, 180 osmolality. I am pretty Oh, I must say, we have not followed them enough for a long period of time to say that this dose will be effective or this osmolality is effective. Discussion. Ask Dr. Manu to know from you how often should be done. Professor Amit also, how often? Because you did MRI practically every year. Is that possible or recommended? Being accessibility is different that you can do every year. How often it should be recommended if you have gone through, Professor Dinesh, that?
Yeah. Dr. Manu, would you want to take? Yeah. So, General Verma, just a clarification. Your point's well taken. When we are talking about increasing the liquid intake and when we are giving tolvaptan, there are two different things. One is actually you are suppressing vasopressin phenomena. Tolvaptan stream up. So that's why I said, please don't take them as complementary. They're two separate entities. You can't
I'm just going by your comment. There
Yeah.
are many people who believe, they say, I mean,
Right.
you have heard the statement, many people believe drinking a lot of water is a poor man's tolvaptan. That you can forget tolvaptan, keep drinking a lot of water.
No,
It is for
I
that
mean,
benefit will not be there with
I
that.
don't think so. No.
So I think answering your question, sir, there are two aspects. One actually, which is against the very essence of Mayo classification. They want to particular day what is going to happen. So that is why you will, based on the so many times you are in a class one, you have your undecided which way the patient is going. Now, if over a year's time you believe that rapid downhill course, the which is something which was not expected, which maybe Mayo may not be able to predict because there is something which is peculiar to pro PKD score now. Now, if this patient were to have a urological event, has to have some hypertension which is uncontrolled, is a male, so then obviously you get that kind of extra confidence to be able to use tolvaptan, because this, as we all have discussed, is not a drug which you can club it alongside RAS inhibitors. So you have to be very sure as to whether, and it's an expensive at the same time. And if you are looking at 5 tablets on a daily basis, and as Professor Gupta wanted to know what is the endpoint, the endpoint is like an addiction. If you believe your patient is getting some usefulness, you may want to continue using it. But if the second MRI after the use of tolvaptan says that your patient did not benefit, why would I want to use a costly drug?
To
I-
add on to Dr.
yeah, please, Professor Amit Gupta.
Yeah. No, actually, there is a limitation of using MRIs. One is our radiologists are not very well trained to sort of analyze the MRI and give us the total kidney volume in some extent. And two is the cost. So I would suggest that we should go, which is a little more easier to do and perhaps more accessible to patients and a little cheaper, by which we can assess our patient. I mean,
Sir, people, they take the help of ultrasound and extrapolate the way we calculate total kidney volume. That's the easiest and the most cost-effective way. And the one crude way, as we all know, the moment it is more than 16.5 centimeter. But if you go one step further, take the help of and come out with out of that. The ultrasound frequently. I mean, you can do that maybe once in 6 months, by one year. So that's the kind of.
I think there are many gray areas. First of
Sure.
all, admit that both of you, Dr. Manu Dogra and you, did wonderful job. But the gray areas still remain what Professor Amit Gupta asked, and I still feel, one, we still don't know correctly, scientifically, that till what level we should weapon. Whether we should carry on like SGLT2, you say carry on till dialysis. Whether we should carry on till RRT, that's a gray area. Number two, about the dosage, we are still in a gray area that though those people went up to 120, Is it essential to go up to 120? Why? Number three, we do not have any target endpoint. Yeah, why should I keep increasing the dose of tolvaptan till what? Is the osmolality give? No, nobody has talked about that. You should target the osmolality. So they are gray areas. Fourth gray area you touched, that how we should follow them. Should it be the MRI with the gold standard they recommend, or we can opt for ultrasound, possibly, which is more practical. So it's an amazing topic. And despite knowing so much, discussing for 2 hours, I think there are many gray areas which still remain. And I think, as you rightly said, maybe the genetics eventually, maybe the things will come, they will give the answer. Any last minute comment from any of you? Then we close.
Same, I will say. I think we have to move beyond tolvaptan now, and that's why I particularly wanted to emphasize on the role played by the gene therapies. They are not in use at the moment, but then if someone has received a Nobel Prize for such an exciting thing as recent as in 2020, I'm sure people are on the right track. Ultimately, this is what we want to do. We want to set things right, take care of the genetic imbalance, mutations, rather than taking care of the effects and trying to slow down the rate of progression with tolvaptan or this thing. But then when I was saying that up to end-stage kidney disease, these are some mention in the guidelines that once you have started them late, and obviously that late is obviously not below 25. The way we had in, I would say, DAPA CKD, you would start them at 25, but they will not stop at 24.
Yeah.
So you will have some endpoint in mind. That was typically the 15 ml of GFR. You can have, but answering your point again, sir, we have to have a surrogate marker. We have to have some endpoint, and urine osmolality precisely does that for us. And the reason why I may have gone up to 90 milligrams in a few of my patients was that the urine osmolality may have fallen to something like 300, but it was not coming beyond. And my own thing, the target is to bring it below 200, because
Precisely.
somehow I believe that
That is
less than 200, and if you achieve that with 30 milligrams, I don't think there's any point going up to 45 also.
I fully agree.
And Dr. PP
Amit
Varma,
Gupta,
you should take some questions, because there are some questions in the chat box, one or two.
I think there are a couple of have been answered. It is useful to give lower dose of tolvaptan. Will it be subtherapeutic? We don't have the answer. That if you are targeting osmolality, yes, you target the osmolality, preferably less than 200. But that is our feeling. That is not a study data as on now. That what we should, because the study has only gone up to maximum tolerable dose of tolvaptan. The other
Sir,
point
we should be rather doing regular imaging, sir, so as to see whether the tolvaptan has slowed down the size of the kidneys.
Yes.
We should be doing regular imaging, sir.
I think I would agree with that, Dr. Manu, because otherwise, so there's only urine osmolality you are relying on. But I think at the end of the day, you started tolvaptan because you saw something on the imaging, and I think it's our responsibility to make sure that that thing has been arrested to some extent.
the last question, it was by Dr. Ram, I think. Good evening. If family history is positive with typical presentation, like in the present case, but no one from family has undergone genetic testing. Here, genetic testing should be done, query. Should it be done? It will help in prognosis also. So possibly he is advocating that maybe genetic testing may be useful. Fine.
I think we should repose our faith in genetic testing. Gone are the days when it was out of reach for most of our patients. Now that it has become relatively cheaper, and the kind of information which we can get, you see, so many times you may believe that it is type 2. It may actually be type 1. You may be missing the bus if you've already allowed the patient to go on.
Yeah, many times you are getting something atypical cases. All of us have seen. Sometimes you find person has got 4 cysts or 5 cysts in each kidney. Well, should he be labeled as ADPKD?
Yes, it depends upon
If
whether
the
there
family
is a
history.
family history or not. If
There's
the family history is not
history.
there, sorry.
Because that is only if the family history is there.
Yeah. So I think genetic testing also, I mean, you'll have to be careful while you get your test done, because these are still expensive. And so if you have a strong family history, if you're someone with obvious cysts, there's no need for a genetic. But obviously, if somebody is going to be a potential donor, there I think the role of the genetic testing is extremely important.
I think I'll stop here. It is a fascinating discussion, and I think all of us are enthusiastic about and to discuss further. But thank you very much, all of you, Professor Khullar, for excellent overview, Dr. Manu Dogra for very interesting case, and Professor Amit Gupta, as usual, for mature comments. Thank you very much.
Always a treat to listen to him, and special compliments to Dr. Ravi. You did a fantastic job, and Manu, I mean, is always very good to hear you. And as I said, General Verma, there's no one matching you as far as it comes to moderation.
Thank you so much.
Indeed.
Thank you
Thank
so
you,
much.
sir.
Bye-bye. Thank you, Steadfast. Puneet, anything?
No, sir, I just want to thank you for such an exhaustive session.
Right,
It's almost 8:30, 8:41. Thank you, Dr. Khullar, Dr. Amit Gupta, and Dr. Manu for such a nice session. Thank you so much.
Thank you.
Thank you, sir.
Good
Thank
evening,
you.
everyone. Good evening.
Evening.
Good evening, Madam Anuradha.
Yeah, good evening. Wonderful,
evening.
wonderful. Yeah. Good evening.
Thank you so much for the opportunity. Right.